Moving on now to left heart failure. So we just got done covering all the specifics of right heart failure. We're going to be able to apply a lot of what we just talked about to left heart failure. Some things will stay the same, some things will obviously be different because we're talking about the other side of the heart. So still an atria and ventricle, still pumping blood, still has its own preload and afterload and all that good stuff, but it's pumping blood to a different area of the body and it's receiving blood from a different area of the body. So that fundamentally is going to change things here a little bit. So you'll see some commonalities between the two, and you'll also see some big differences. So we will go over all of those. So let's go over the causes just to start. What's going to cause left heart failure? So those are things, well, you know what? I don't even have my little drawing yet. So let me get my friendly heart back. So this time we're going to have things shifted over. Before I had it shifted over to the other side, now it's going to be like this. And we'll just put some cheap little lungs back in here. That lung looked bad the last time too. I wonder what that's all about. So pulmonary arteries, pulmonary veins, something like that. We've got atria and ventricle. Then we've got our wonderful aorta here, or what's supposed to be our aorta, going out to all the arteries and tissues and the whole rest of the body. And then it all goes back that way, and we know it would eventually wrap around like this and connect to the right atrium, but I don't need to draw that right now. On the previous drawing, I already basically outlined the expected direction of blood flow, what we mean by pushing blood forward in circulation and all that, so I won't include that in this video just to keep things as clean as possible. I will, however, put this up here just so we're square. And then at some point we're going to need a C membrane because I inevitably refer back to that in almost all my lectures, so let's just go ahead and draw it right now. Okay, this times about 300 million, give or take, down here in the lungs as a whole. So let's talk about this. Causes of left heart failure. Left ventricular infarct. Sure, I think this is what I'm going with for infarct color right now. So, infarct. We're going to talk about that specifically in the next video. We're going to talk about MIs. All the vascular stuff starts next. So this whole area is infarcted. I should have drawn this as extra thick and muscly and everything, but you guys know, because you're experts about all this cardiac stuff, right? You guys just knew by default that this left ventricle is much more massive than the right ventricle. So even though I didn't draw it that way, I know you guys already knew that. Anyway, we end up infarcting this whole thick muscle wall. We'll just say it's really bad. The whole muscle wall gets infarcted, not just a tiny part of it. And we know that this now dead tissue isn't going to beat like regular healthy cardiac tissue does. So all of a sudden that's lots of pumping capacity, that's lots of squeezy force that this left ventricle can no longer generate. So left ventricular infarct, absolutely going to make it so that the left side of our heart begins to fail. Systemic hypertension. When we were talking about the right side, it was pulmonary hypertension that made the right side fail. In this case, we're talking about the other side. It's going to be systemic hypertension that's going to make the left side fail. And that's just going to be because we've got hypertension out here, just regular good old garden variety hypertension, not pulmonary hypertension, which is up here. That just basically means all these blood vessels are going to be narrowed or blocked or hardened and non-distendable for some reason, so the pressure is increasing. And if that stays increased for a long enough time, just like we saw in our last video, all that fluid that should be freely flowing through all these tissues at a normal rate can't do that because all these blood vessels, like we just said, are blocked or narrowed for some reason. So that fluid begins to back up. It backs up and backs up and backs up. But remember, this is all systemic arteries. So if we were to measure our patient's blood pressure, the pressure goes up and up and up because that fluid isn't flowing through easily. Well, where does it eventually work its way back to? All that pressure is going to exert a force on the left ventricle, which is usually really strong and I keep saying meaty. I don't know if that's exactly a good term to be using, but you guys understand what I mean. It's got a very thick wall. There's lots of muscle cells. It has lots of contractile force. So it can put up with hypertension for a much longer period of time than the right side can. So just for effect, I'm going to draw, just so we know, we got big, thick chamber over here. This is a thick chamber. Thick and strong and just awesome because it's the workhorse chamber. It's the one that does the most work because it has to pump through the most vascular resistance. So there we go. So it can put up with this whole hypertension thing for a lot longer than this side can. This side can put up with hypertension for a little bit, but prolonged pulmonary hypertension is going to just destroy the right side of the heart fairly quickly. On the other hand, I'm sure you guys have, you know somebody, have a friend, family member, whatever it is that has either had or has hypertension, and they're not like deathly ill or anything like that. I mean, it's not good to have hypertension, but just regular old, I just call it garden variety hypertension. Your blood pressure is just a little higher than it should be. That is nowhere near as deadly as pulmonary hypertension. And it all comes down to the fact that this left heart right here that I keep scribbling in, it's designed to work against a lot of resistance. It's designed to generate a lot of pressure. It has to push blood through your entire body. The right side was only designed to push blood through a relatively short run of blood vessels. The actual length of all the blood vessels, if you put them end to end in the pulmonary vasculature, is many, many times shorter than if you connected all your systemic blood vessels end to end. So the right heart just doesn't have that much resistance to fight against, so it doesn't have to be thick. The heart never evolved, the right heart never evolved doing a lot of work, so it's not used to that. So if you increase the pressure in here for too long, for just a little bit, that right side begins to fail. The left side, it's a different story. It's the workhorse, it's the strong chamber. It can put up with hypertension for a while in most cases. So that's why we said hypertension, just regular old hypertension, although it is not good, it's certainly not the deadliest thing that we have to worry about. Anyway, so that's why systemic hypertension would potentially cause this heart to fail. All the fluid just can't move through. Eventually there's going to be an accounting for that. The heart fails and fluid backs up and backs up and backs up, and now look where it's backing up. All of that fluid is starting to back up and engorge the pulmonary vasculature, and we talked about that when we talked about restrictive diseases and pulmonary edema, specifically cardiogenic pulmonary edema and things like that. So we're going to get a much clearer picture for why that happens. But anyway, that's our systemic hypertension. Maybe that systemic hypertension is the result of peripheral vascular disease. So that's what PVD stands for, PVD, peripheral vascular disease, versus something like CAD, coronary artery disease. Just a few more abbreviations for you. Anyway, these are just different vascular diseases. There's lots of them, but it's things like, arteriosclerosis and all kinds of other things like blood clots and diabetes and all kinds of other things can cause peripheral vascular disease. So what the net effect of those diseases is a lot of times is to cause hypertension. It doesn't permit blood to flow smoothly through those blood vessels, which raises the pressure, and we just talked about the effect of prolonged systemic hypertension. It's this right here. It starts to back up into the left side and cause the left side to fail. Mitral or aortic valve diseases. How many backups am I going to have to do to get this to go away? Sweet. Back to normal, except I am going to scribble in here and make this the big thick chamber. Rah, 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 rah. Thick chamber. Oops. Okay, whatever. It's got a little appendage in there. Whatever it is. Anyway, on to mitral and aortic valve disease. We covered the pulmonary disease, or the pulmonary valve and tricuspid valve when we talked about right heart failure, all of those being right-sided structures and connecting to the lungs and everything else. We're obviously on the other side, so we're talking about different valves. We've got a valve right here. Remember I mentioned the term AV valves, the valves that go in between the atria and the ventricles. Well, the AV valve on this side is the bicuspid valve, also known as the mitral valve. So whatever, what color am I going to draw that in? So there we go. There's our mitral valve, or our bicuspid valve, and it actually only has two cusps, two big leaflets. Keep in mind those AV valves are much, much bigger than semilunar valves. And then over here, this, well, obviously not anatomically correct, but whatever. This is connecting to our aorta, and we know if it's going from a ventricle to an artery, then that has to be a semilunar valve. So that is our aortic semilunar valve right there, or just for short, the aortic valve. So call it whatever you want. The mitral valve or the bicuspid valve, that's totally fine. Call it the aortic valve, but know that that is sort of an abbreviation. It is technically the aortic semilunar valve, if we're being 100% complete about that. Of course, this heart failure can be idiopathic. We talked about that with lots of other diseases, as well as right heart failure. The left side can fail for no particular reason, or it can fail because of something like steroids. We talked about that, or other drug use. All the same reasons apply, the same reasons for anabolic steroid use, stressing out the heart and everything else. Other drugs, a lot of the drugs that we're going to blame are going to be the stimulant type drugs, or contaminants and other intravenous drugs, that sort of thing. All of that remains the same. And then patients who have high BMI or high body surface area, that's a very nice way of referring to our larger, significantly overweight patients, saying high body mass index or high body surface area. So having a high body surface area doesn't necessarily mean that our patients are significantly overweight. Our patients just might be really tall. So like you think Andre the Giant, he had lots of body surface area because he was gigantic. But you can also have like a really, really short person, picture somebody who's 4 feet tall, but they weigh 300 pounds. They're going to have a lot more surface area on their body compared to someone else who isn't overweight, who is their same height. That's the example I'm trying to make. So whether it's represented as a larger body surface area than you would expect for their height, or their actual body mass index is higher than it should be. The higher these numbers go, that just means, like we were talking about on the last video, there's more tissue to support. Your heart doesn't discriminate if it's muscle, if it's fat, if it's more of any kind of tissue. That's just more tissue that your heart needs to supply blood to, and the more of it there is, the harder the heart works, and the more likely it is to fail prematurely, or fail just in general. So that's the link between high body mass index or high body surface area and heart failure, left heart failure specifically, because remember, all of that congestion, all that backup is coming from out here. So whether the congestion comes from out here, vascular disease, high BMI, something like that, whether it's the muscle itself that fails for all the reasons we described, if it's one of these valves that regurgitates like we were talking about, blood just kind of scoots back and forth, it doesn't actually move forward, or if that valve is narrowed and stenotic for whatever reason, blood just backs up behind the problem, behind the car crash, and all the stuff that's expecting to move through the left side of the heart just keeps arriving, and it just has to sit there and wait. So it backs up, and there's our increases in vascular pressure, and eventually our pulmonary edema and stuff that we're going to talk about here soon. So moving on, signs and symptoms of left heart failure. Knowing all of this stuff we just talked about, just do like a quick little mental flashback to the right heart video you just watched, and all of the problems we were seeing, all the problems came from the lungs or the right side and backed up into systemic circulation. Here, all the problems come from systemic circulation or left-sided heart problems, and they back up into pulmonary circulation. So we're going to see distinctly different problems, some of which we've already heard of. So the basics of what's happening, we'll just word it out for you. The fluid, which should be efficiently pumping through the left side of the heart, is not pumping efficiently, so the fluid backs up. This time, the backup isn't going into the systemic veins like we said, it's going into the pulmonary vasculature. We can measure those resulting pressures with invasive monitoring. Like I said before, we can get really fancy and invasive and stick all kinds of catheters and devices into the heart itself, which is sounds crazy, and it kind of is, but that's something that we as healthcare, just healthcare as a whole, has the ability to do. We can catheterize hearts, we can catheterize different veins, get pressure measurements, flow measurements, all kinds of stuff. It's actually really, really fascinating. So we'll get into that, I promise. We can do all that crazy invasive stuff, or we can take some more simple, less invasive, easier approaches to figure out this is what's happening with our patient. So we've already talked at length about cardiogenic pulmonary edema. This is the cardiogenic pulmonary edema right here. This wouldn't be high permeability pulmonary edema or non-cardiogenic ARDS type pulmonary edema. This is very much due to the fact that the heart failed. Why it failed is kind of irrelevant at this point. Even if it failed due to hypertension out here in the systemic arteries, at the end of the day, this heart failed, that fluid is backing up into the lungs, so it is cardiogenic. That pulmonary edema is the result of this heart failing. So that might clarify, if you had any lingering questions about our pulmonary edemas, that might clarify exactly why cardiogenic pulmonary edema is what it is. And of course, we talked about those pink frothy secretions from alveolar flooding. Remember, it's all the pressure, all the fluid pressure that's building up in these pulmonary blood vessels here. So back up into all the pulmonary blood vessels, just like this. And the blood isn't really leaking out. This patient isn't hemorrhaging. That's an important point to drive home, so I always make that point. It's just the fluid component, because we know that your blood has fluid and it has solid things in it. That fluid is going to squeeze its way out of these vessels into the interstitial spaces. So we'll definitely see interstitial edema. I'm sure we remember that. And we're going to see alveolar edema. So think back to the pulmonary edema video. That's a double whammy. That's all the weight of the water pushing down on the lungs, trying to collapse them, and the flooding of the air spaces, which makes gas exchange even worse, compliance even worse, dilutes surfactant, increases surface tension, on and on and on and on. And along with that, so there's all the fluid, and every now and then a red cell makes its way out. So it's mostly water, but it's got a few red cells floating around in there. So when the patient coughs these secretions up, that's what gives them the pink appearance, and the frothiness comes from the fact that CO2 is still diffusing out here. CO2 is still trying to make its way out, and the patient is ventilating and has little tiny bits of air moving back and forth, but there's so much fluid and there's all this like protein and all this other stuff in there that it ends up kind of frothing up, kind of like when you crack open a soda bottle after you shake it. It just goes whoosh, and it fills up with foam, and that foam just goes drizzling out everywhere. That foaming action is kind of what's happening right here in these lungs with cardiogenic pulmonary edema. It's mostly fluid getting squeezed out of the blood vessels and into the lung tissue and the air spaces themselves. So that's the fluidy part mixing with surfactant and a few red cells that inevitably find their way out. But the patient is not bleeding out their lungs. If they're bleeding out their lungs, they cough up actual blood, and it's very noticeably different, and we call that hemoptysis. I think you guys probably covered that in patient assessment. So that's our recap of pulmonary edema here. What else do we see along with that? Patient complaining of orthopnea. So that's just another PNEA word that we have to be familiar with. So orthopnea, describing that it is very difficult for your patient to catch their breath when they lay flat. And the reason this happens in patients with left heart failure in a lot of cases is because when they sit upright, all that fluid, so remember this times 300 million, all of this is going on, or at least it's going to start out down here in the bases of their lungs. Because like I said in the previous video, we spend most of our day upright in some capacity, whether or not you're walking or sitting or Even if you're reclined on a couch for the most part, your feet are still low, and that means the bases of your lungs are lower than the top of your lungs, and water will follow gravity and accumulate at the bases. So a lot of times this edema is going to start building up in the bases where all the water accumulates and the hydrostatic pressure is higher, and eventually their lungs just fill up with this fluidy froth, and the gas exchange just gets proportionally worse, as you might imagine, because we're collapsing our lungs and losing surface area and all those other horrible things that we talked about. So let's take some of these away. Let's say the patient's only at this stage. Well, the thing to realize here is that only a little bit of the lung is flooded. It's just the bases. Sure, the patient will notice that it's hard to take a deep breath. They might even feel the crackles a little bit as they breathe. They might feel like their lungs are congested a little bit. But what they'll do is they'll just increase their respiratory rate a little bit, and they will still ventilate all this area up here. That's one of the advantages. When they lay down, this fluid, which accumulates in the bases primarily, say they lay down, and most people lay down on their back. Very rarely do they lay down on their face or, in any other kind of weird position for a long period of time. This patient's going to lay flat, so let's lay him flat. So there we go. He's laying flat. And here's his lungs. So anterior. I don't know what that is. I'm sorry. Anterior, posterior. So he's laying on his back. Well, you have the majority of your lung tissue actually in the posterior aspect of your chest. The majority of your lung tissue sits towards the posterior. You have a fair amount in the anterior, but most of your lung tissue actually sits in the posterior. So that's going to be something we have to keep in mind as we go later on, because that's going to have an impact on the way we do certain things. But in this case, what that means is instead of this fluid just accumulating in the bases of the lungs in general, it's going to accumulate in the posterior of the lungs in general, which is the majority of your lung tissue to begin with, and that makes them very noticeably short of breath. And depending on how bad this flooding is, it's really noticeable really quickly. Like this patient will lay flat and almost immediately they feel like they can't catch their breath, and it's because this fluid redistributes and it floods the majority of their lung instead of just flooding the bases of their lungs. So that's why they complain that they have a hard time catching their breath when they lay down. Another way of describing that is I can only catch my breath when I'm sitting up. Those are both describing orthopnea. The opposite of that would be platypnea, where your patient can only catch their breath laying flat. They are short of breath sitting up, which is kind of rare, but it happens with weird heart defects and stuff. We'll talk about that later. So that's our orthopnea. Talked about the opposite of orthopnea, which is platypnea. There's dyspnea, as we know. That's just the patient reporting shortness of breath. That's our fancy term for shortness of breath. And then, of course, those inspiratory crackles, particularly in the bases, like we've been talking about, because as this patient tries to expand their lungs and take a deep breath, we're going to hear these flooded alveolar units make that distinct crackling noise as they pop open. So kind of like that hair crunching, crinkling plastic bag noise, but instead of a dry crackle like atelectasis, this is going to sound like a very, very wet, literally like a fluidy crackle. And I know that sounds kind of weird right now. You're like, oh, wow, okay, thanks, that helps a lot. Well, I promise you, dry crackles, dry atelectasis crackles sound distinctly different from mucus crackles, which sound distinctly different from pulmonary edema crackles. It's just something you're going to have to take my word for now. I have some good stuff that you can use to practice breath sounds with. We'll bring that up a little bit later on. But I promise you, all of these sound different. So all these little descriptions, all these words mean distinct things. So if they're giving you a very wordy description, or you're reading a patient assessment or something, and it gives you a very exact description of a breath sound or a finding, it's because they're trying to tell you that there's a very particular thing going on. So probably going to be inspiratory crackles, a lot of them. As this gets worse and worse, we'll hear expiratory crackles too, just because there's so much fluid in the airway. And they're going to be these very, very wet type of crackles, and they're going to be fine because they're in the alveoli. They're not in the big airway, so they're not going to generate those heavy, flappy, coarse crackles like mucus does. Anyway, what else are we going to see? It's our workhorse chamber that's failing. So, of course, we're going to see some hypotension. You take this patient's blood pressure, and once this heart really starts to fail and they decompensate, their blood pressure is going to stay low. And low blood pressure can be just as problematic as high blood pressure because we're not actually feeding enough oxygenated blood to the tissues. It can actually get so low to the point where your patient's heart is still beating, they're still circulating blood, but remember, they're not taking care of that final priority of medicine, the perfusion. They don't have blood pressure that's not pushing blood out to their tissues. So even though their heart's beating and the blood is circulating, they're not actually pushing an adequate amount of oxygenated blood to their tissues, which we know as tissue ischemia, and that can lead to a whole lot of issues, obviously. Like, that's one of the big things that happens in sepsis patients. You just cannot keep their tissue perfusion up. It's for a different reason than what we're talking about here, but it's just trying to make the point that it's possible for your heart to beat and circulate without you perfusing your tissues. And as we know, that's one of the missing priorities of medicine, and if that persists, our patient is unfortunately going to expire because that's not sustainable. So hypotension, definitely, because our pump here, for whatever reason, is failing. If you were to put your fingers on a pulse point, that pulse is going to feel very weak and thready versus being like strong or bounding for a patient who has good blood pressure or high blood pressure. A fun fact, the further away you get from the core in a patient like this, the weaker the pulse will feel. So if you're feeling like a carotid or a femoral pulse, something that's very central towards the core, it may still feel weak, but that's where you're going to feel your strongest pulses. As you move away to more distal pulse points, like your brachial or popliteal artery, or even further down, like the radial or the dorsalis pedis artery, you'll feel those pulse strengths significantly diminish or even completely disappear as you move out towards the patient's periphery because their perfusion is so poor. If you do that quick and easy little test, the capillary refill, so everybody take a look at one of your index fingers. It's got a certain amount of color in it. You squeeze it real hard with your other hand and it turns white real quick because you push all the fluid and blood out of it. And right when you let go, it should turn right back pink because you have good perfusion, you have good blood pressure, and as soon as you let go with your other hand, all that blood pushes its way back into the tissue because you have good perfusion. So normally it's about 2 seconds or less. If it's anything longer than 2 seconds, the longer it is, the worse the perfusion. That's the easy way to think of that. Now, why does decreased urine output, why does that have anything to do with heart failure? We're going to learn, I keep saying in detail later on in hemodynamics, we're going to learn extensively about the link between kidney function and cardiac function, but for now we can just scratch the surface on it like we're doing with a lot of other things. Just think about it in terms of supplying blood flow. Like we already said, our lungs, if our heart fails, if our right heart fails and can't pump enough blood to our lungs, then our lungs can't do what they do. They can't oxygenate the blood. They can't perform gas exchange, so our gas exchange suffers. If our left heart fails enough and it's not pumping enough blood to the kidneys, your kidneys are really blood-hungry organs. Your kidneys get a lot of perfusion, like a lot of perfusion. They just, whenever you see somebody get a CT with contrast and it captures the kidneys, I mean, those kidneys just light up like bright white because there is just a ton of perfusion in there. The reason for that is because you need to pass a lot of blood through your kidneys so that kidneys can do what they do, which is, of course, help filter out certain waste products, proteins, balance electrolytes and fluid and all those other things, and keep a lot of your blood parameters in check. It doesn't control all of them, but it does control a lot of them. And if you're not pushing enough blood to your kidneys, I'm making the lung analogy. It's just like if you don't push blood to your alveoli, you can't perform gas exchange. If you don't push blood to your kidneys, you're not pushing blood to all those little nephrons. You're not creating glomerular filtrate and all those Bowman's capsules. The nephrons don't actually get to work because that kidney itself is not being perfused. So the simplest way to think of it is it doesn't get to do kidney stuff, and kidneys are famous for making urine. So If your patient's urine output is decreasing, of course that could be from kidney failure or disease or something like that, or some sort of a urinary blockage. But in this context, the decreased urine output is coming entirely from the fact that they are not being perfused enough, so they can't do what they're supposed to do. They can't filter the blood, remove waste, and make urine. And that kind of has a horrible effect for these patients with heart failure, because we already said in a lot of cases, this heart failure is due in one reason or another to fluid backing up, or for one reason or another, it's due to fluid backing up. And if fluid backs up, the last thing you want to do is start having your patient hold on to extra fluid. And I mean, that's true for left heart and right heart failure. If that heart is already having a hard time pumping the fluid that's demanded of it normally, you don't want this patient to have any sort of excessive positive fluid balance. You don't want extra fluid on board, because that's extra fluid the heart can't pump and it fails even more. So the symptoms get worse. So it kind of makes this vicious cycle where the heart fails, they can't perfuse their kidneys, so their kidneys can't eliminate fluid. The fluid builds up, which makes the failing heart fail more, so they perfuse their kidneys even less, so they retain more fluid, and it's just this vicious cycle where your patient fills up, literally fills up with fluid, their heart stops pumping effectively, and they basically drown in pulmonary foam if they don't get to us in time. So something that we got to worry about. That's my quick little spiel on the link between cardiac function and renal function. And then the bottom things we see here, I've covered a few of the findings on chest x-rays and things. I didn't throw a lot of them in there because that's more of an assessment type of thing. You'll go over those a lot later on in your patient assessment courses and diagnostics and things like that. I'm just throwing out some of the big name ones that I want you to remember for now. We already know what cardiomegaly is, but we're going to be seeing this on the left side specifically, so you will come to appreciate the normal size of a left heart for your particular patient population. And then when it looks all big and blown up, you're like, oh wow, that's a mega big heart. That's cardiomegaly, but it's specifically on the left side. And then if we look in our lung fields, we'll see these things. A lot of times they'll refer to them as fluffy infiltrates, or you'll see what they call a butterfly pattern on the chest x-ray, or this thing called curly B lines. That's curly with a K, K-E-R-L-E-Y, and then just the letter B, curly B lines. They are not curly, nor do they make bees. Curly is just a curly B line. That's just, it's named after somebody, like a lot of this stuff is. So, not going to go too in-depth into chest x-ray interpretation, because that is a whole crazy subject all on its own, and I don't want to cloud the waters here too much. So now, how should we treat left heart failure? We're going to get to apply some of the stuff we talked about with right heart failure, some of the treatments to our left heart failure patients, but that's not going to be a 100% carryover. Some of these things will work for both types of heart failure. Other ones not so much, because as we're learning, it's a different side of the heart. It affects different things. So of course we're going to have different treatments. So at the end of the day, as you might have guessed, that treatment is going to aim to restore effective blood movement through the left side of the heart, through whatever means are necessary. So it really just depends what's wrong with your patient. Like we talked about in the previous video, you got to have the right tool for the job. So if it's a valve problem, medications are going to have limited effectiveness. If it's entirely a narrowed valve or a damaged valve, regurgitating valve, whatever it is, if that's the entire problem, the heart muscle itself is fine, well, then we shouldn't probably recommend throwing medication at that for too long, because we know what the problem is. The problem is with the valve. So if the patient is a surgical candidate, go in there, open up that chest, replace the valve. Of course, I'm not saying you do that. There's going to be a whole surgical team that does that, but I'm just saying that's the recommendation. If you're answering a question or whatever, they have you doing some sort of clinical simulation and, oh, what would you recommend in this situation? If it's a bona fide valve problem and the patient's a surgical candidate, then just replace the valve. Don't dance around doing all this other stuff when they're a surgical candidate and you can replace the valve. That's what I'm getting at. If the valves are fine, but it's the heart muscle that's failing, well, there's no point opening up the chest and replacing the valve, because that's not the problem. We need to get that heart to beat harder, so that's the role of inotropes. We talked about those. So specific medications, which we will detail greatly later on. You'll learn all kinds of different inotropes, and vasopressors and diuretics and things. We'll talk about it in the months to come. But anyway, we mentioned what those are. They're meds that are specifically going to increase the contractility of the heart muscle, not the speed of electrical conduction, not the heart rate. Those are all separate classes of drugs. Diuretics control fluid balance. We actually just talked about why fluid balance is so important, whether it's right or left heart failure. At the end of the day, the patient's heart has a hard time pumping the amount of blood that it's supposed to pump. Blood is fluid, and if the patient has more fluid on board, more positive fluid balance is how they'll refer to it, all that extra fluid is going to stress the heart even more, so we're going to want to use diuretics to control that fluid balance, because diuretics make your patient pee. When it comes to vasodilators, I'll just try to go through these as quick as I can. We already know that vasodilators increase the size of blood vessels. There's a couple different ways of doing that. Some of them actually relax those vascular smooth muscles. Some of them stop the smooth muscles from contracting, which I know sounds the same, but is a little bit different, kind of like the difference between adrenergic and anticholinergic bronchodilators. One actually makes the muscle relax. One stops that constant signaling cycle that makes the muscle contract. So similar method of actions, but distinctly different. In this case, we're talking about vascular smooth muscles. So there's a couple different ways to get those vascular smooth muscles to relax and keep them relaxed. What that's going to do, that's of course going to decrease the afterload and improve flow through the blood vessels systemically, so the left side of the heart can function a little bit better. And notice there's a couple of different drugs that we're not mentioning here, or that we didn't mention in our previous video. So there's no nitric oxide here. Nitric oxide, we'll learn about it in Therapeutics 1 in detail. Nitric oxide inhaled is an awesome pulmonary vasodilator, as we learned, but it is metabolized so fast that basically the instant it hits the pulmonary vasculature, it's metabolized and is gone. So none of that nitric actually makes it out to the left side of the heart and into the systemic circulation. So that's why when we give it inhaled, it's specifically referred to as a pulmonary vasodilator. That obviously is targeting the wrong area of the body in this case, so nitric oxide isn't going to do anything for left heart failure. Nitric oxide will actually make left heart failure worse, because you'll just cause all the pulmonary blood vessels to open up and dump more fluid into a failing left heart. So basically just goes back to the whole idea of got to have the right tool for the job. Nitric's really only going to be effective for pulmonary problems and right-sided heart problems, not left heart failure. ACE inhibitors and angiotensin receptor blockers, those are another one of the items that we're going to cover when we get to hemodynamics and go through all our fancy cardiac drugs. There's really no easy way to explain that quickly, so I'll just leave it at that. At the end of the day, ACE inhibitors and angiotensin receptor blockers both have the function of helping your systemic blood vessels relax. It's mostly systemic blood vessels. A lot of these drugs, again, they work on specific areas of the body, whether it's certain organs or certain vascular beds. Not all blood vessels are the same. We already know that, difference between arteries and veins and things, but different blood vessels, different tissue beds regulate their blood flow slightly differently. So not every drug that vasodilates every single blood vessel. I know that's kind of weird to think about, but a lot of these drugs are very targeted, very specific to certain areas. Calcium channel blockers, there's actually a couple different types of those that we'll learn about. The one we're focusing on is the dihydropyridine type of calcium channel blocker. I think they also do sometimes use those for patients with pulmonary hypertension as well, but classically we see those a lot with left heart failure patients. Nitrates, just a general class of medications that are vasodilators, so you probably heard of the big ones. So nitroglycerin is one of them. Patients who have a lot of chest pain a lot of times take nitro tablets or something like that. But there's a lot of different nitro or nitrate drugs that are all vasodilators that'll help open up those systemic blood vessels and alleviate the workload on the left heart. And then another drug class called alpha blockers, not to be confused with beta blockers, because they're slightly different. You guys have probably talked about alpha and beta receptor sites in pharmacology. Alpha blockers, just remember alpha goes with blood vessels. There's a little bit more to it than that, but the easy way to think of it is alpha goes with blood vessels. Beta is going to go with either our airways or our heart. So the easy way to remember that is beta 1 and beta 2, you have one heart and you have two lungs. So beta 1 receptors, you have one heart. Beta 2, you have two lungs. So that might help you out a little bit with pharmacology type stuff. They're both beta receptors, they're both adrenergic receptors, but they're both shaped slightly different. They respond to slightly different molecules. And beta 1 receptors primarily proliferate on the heart, beta 2 primarily in the airways. So anyway, if we block beta stimulation, since we would be blocking adrenergic stimulation, we would be blocking the fight or flight response. So that would have the net result of keeping that heart beating nice and slow and steady, which is important in a lot of cases, especially diastolic heart failure, where we want that heart to be nice and slow and steady and chill, so it has plenty of time to fill. And remember, we're hoping that this isn't going to affect the contractility too much. We're still going to encourage contractility. We just don't want that heart to beat really fast. We want it to be nice and slow and steady so it has plenty of time to fill. Non-invasive ventilation for instances of exacerbation with cardiogenic pulmonary edema. So when a patient has a really bad episode of their heart failure and they end up like this that we're drawing right here, there's a couple of things we do for them. Non-invasive ventilation, just being one of the big ones. And then of course we recognize all these surgical options, the valve replacement, if that's the answer, VAD placement, so ventricular assist device, a little electronic pump that sits in the chest, is connected to an exterior battery pack, and it basically takes over the majority of the workload for the ventricle. It's actually kind of cool. And then of course the mother of all cures, the transplant, but it's very hard to get matched for a transplant, particularly a heart, because hearts, they're one of the least available, if not the least available organ for transplant. So it's not quite as common to see heart transplants as it is something like kidney or liver transplants and things like that. So if the patient's a surgical candidate and they get matched, then they get a transplant. There's also these cool things called total artificial hearts that we'll mention again in hemodynamics. I'm just kind of foreshadowing cool stuff that we'll go over. But they do have total artificial hearts that basically function completely as the patient's heart, but it's a mechanical device. Now, the real quick touch on CHF, congestive heart failure. People are probably wondering, well, what's the difference? What's CHF? How's that different from left heart or right heart failure? Basically, what's happening in congestive heart failure, that basically means that both sides of the heart have failed. So we're basically seeing right and left heart failure simultaneously. The whole congestive part of it, it's arguable that all of these heart failures are due to congestion. I mean, you're congesting the vessels on one side or the other, and it's causing the heart to fail. But that term CHF really is used to describe the fact that the left heart is congesting the right side of the heart. So I have all this backup drawn right here. Let's just say that this patient, they don't have horrible pulmonary edema right now, but their left side of their heart is failing, and this blood, this fluid, this pressure is just continually backing up. So backing up and backing up. It'll eventually back up through the lungs, and it'll back up into the right side, and oh, look what I just did. Now I'm causing right heart failure as a result of the left side failing. So not because the lungs had a problem or anything like that, but because the left side failed, this all backed up, congested all the way through the lungs, through the pulmonary vasculature, and now my right side is being congested and is failing. So that's really what's meant by congestive heart failure. The whole thing is basically blocked up and fluid can't flow, and you're going to see signs and symptoms of both right and left heart failure. So all the stuff we've talked about related to right and left heart failure, that's what we're going to see, and the patient is significantly at risk for secondary problems now, because either side failing, either side of the heart not being able to function is a huge problem. But having both sides not function at the same time, that's you can obviously tell that's just an even bigger problem, so it makes this patient's course of care more complicated. So hopefully that kind of clarifies CHF versus left and right heart failure. CHF is typically from the left side failing. It starts out as left heart failure, and eventually it just gets so bad that it ends up blowing out the right side of the heart, and the right side fails as well. Just so you guys know, in practice, a lot of people just lump left heart failure and congestive heart failure patients together. They say, oh, it's left heart failure, it's CHF. It sort of is and it sort of isn't. I think the reason a lot of people do that is they're just assuming that, like, in the hospital, when a patient is hospitalized with some problem related to left heart failure, it's usually because it's gotten to the point where they have CHF at that particular point. So I just want to throw that out there. A lot of times people will just lump them all together. They'll say, oh, the patient has CHF, when they maybe only really have left heart failure. But it's just it's not that big of a deal. It's not like you need to like start knocking people for that or anything. It's just, I want you guys to be square on the terminology. That term congestive heart failure is really referred to the congesting of the right heart by the insufficient left heart. So there we go. The next thing that we're moving on to is going to be MI, but I'm going to save that for another video, because MI, even though it's going to affect the heart, it's technically a vascular disease. There's something going on in one of the coronary blood vessels. So we'll save MI, all the coronary vascular things, and pulmonary vascular things for other videos. So make sure you answer the questions and complete the checkpoint.